Okay, so let's move on to reading and doing ethnography. So my plan is, today we have these readings. Tomorrow we have, well, a little more readings, fewer readings, and a discussion of the observation activity that you did. And hopefully you saw Sudarshan's email, clarifying that if you want to use some other location, you were going away last week and you want to do this in some other place, that's fine. Just as long as you follow these guidelines. And so you could just substitute whatever place for what you see here. And so we'll have you share some of your observations in class tomorrow from what you did. In addition to discussing the readings, yeah. Maybe the second half of class, you talk about what you found. Oh, well, you can actually in this you can just be observing, or you could pair with someone who speaks Malayalam, yeah. Mm-hmm. But these do not these do not really require conversation, only observation. You can be in the library observing what people are doing with their time. You can be in that little what is it called here, cafeteria, small eatery, the ground floor near bus parking. Sit and have a tea and watch what happens. Who comes and goes, who sits, what the interactions seem to be like. Note, as it says, note down what you see and hear fully and neutrally as possible without making any interpretation. And then interpret. It actually strikes me as I think of the locations on campus. These are very quiet locations. Not very much activity. You go into the town, or Palakkad town, or any town in India, right? And you observe any street corner, you'll have a mountain of observations, right? So many things will be going on. So you could use one of those spaces. I mean, I just took a walk yesterday, near the Hamsanandi guest house. I went into the neighborhood, went in a just semicircle through the neighborhood and around, and it's like fascinating. I see so many things, I'm observing that the houses, this is I think a traditional thing in Kerala, each have the same picture on the front wall because of some neighborhood association or something. There's a temple. I can read what it says in Malayalam. It seems a temple to Brahman, which is rare to see. Brahman Devi, like Brahman. I've never heard of that. Maybe that's something someone could explain. And I'm going through the streets. I'm seeing families. I'm seeing many sewing machines in the front yard. One woman's repairing the sewing machine. Another sewing machine is just sitting there. I'm noticing, people must make their own clothes here more often. I'm trying to find the road back to the main road, and as I'm going down that road, a man comes with a herd of goats this way, So I get out of the way, and the goats, so I'm like, village near the university, and there's still goat herding, using the open tracts of land between the houses for the goats to graze. So, so many things happen in 10-minute walk. so off campus may give you more abundant material, or a contrast. If you compare activity off campus, a chayakara, a tea stall in town versus the tea place near the bus. Maybe there's some difference in class expectations that you might observe. Anyway, just let me move on, but yes. Mm-hmm.
So when you are making these observations as a usually we think in first person.
Yeah.
And we immediately are judging so many things based on our past experience. So when we are noting it down, there is no point, there won't be usually points where we already have a past experience with connecting or trying to understand making sense. So when we putting the field notes, we have to subtract out those our influences.
Oh, but you should include your inferences. Yeah, it's just like here it says. Let me just get the. You use the opposite page for writing the interpretation. Interpretation is just whatever comes to your mind. It may be affected by your own baggage and your own biases, but that's fine. And part of the idea in anthropology is as long as we're honest, that it's me interpreting it, the reader can view my interpretation with skepticism. They can decide, oh, maybe, he sees it that way because of this. And am I addressing?
Yes, sir. Like 3 hours in the same room, experiencing the same thing.
Yeah.
Sitting would probably come out with different narratives.
Yeah. Yeah, exactly. Three people experiencing the same thing will come up with different narratives. Exactly, that's true. Yeah, and so you're in ethnography. You're always limited to some degree by, the fact that you're a human in one particular place. In fact, some of us would say that the language, interpretive language of science is in a way an abstract and misleading language, because that language in the third person makes it sound like the author is hovering godlike over everything, seeing everything at all times. In ethnography, you are one person in a particular place, observing something from a particular angle. Or as my graduate school advisor said, you can't stand nowhere. You can only be in you can only be in a place when you're observing. And so the traditional writing of the detached objective style in the third person makes it sound like you are everywhere and you're all knowing. But if you say, what was the example from a recent reading? Yeah, that from the Li Zhang article. I met this woman at a tea cafe. She had ordered us jasmine tea. So you picture this is one person talking to another person. This isn't some universal scientific claim that's being offered here.
So the social embeddedness of the ethnographer is also very much part of the ethnography, right? The question of reflexivity.
Exactly, yeah, that's right. Yeah, and we have to ask ourselves what the ethnographer is usually, well, not always, but can be from a more privileged background, and you have to wonder whether the person is answering the questions according to some perception of who the ethnographer is, trying to please him or her, or trying to be skeptical, trying to get out of the situation as quickly as possible. It's hard to know, but and if we know these things because we write about them, people can interpret them accordingly. You may make some claim, and a person may say, "Oh, that's a good point," but maybe your middle class background is making you not see something, for example. So, in a way, it's by being subjective, you're also being objective, because you're being honest about that you are one person seeing something from a particular place. Actually, let's move on to the readings, because I think the readings for today, they show us some of the aspects of ethnographic research. And then one term just that I'll give you, and that some of you may know. I mean, I know you already know the term field work, because many of you have been talking about your field work. That's not a foreign idea. That's the the thing ethnographers do, but people in other fields, many of you will do that too. Field work often involves participant observation, a term that may be familiar, but that's kind of what you're practicing in the exercises. The exercise for tomorrow, that you're doing now, that we'll talk about tomorrow, is called observation in the syllabus, so that's obviously part of it. This refers to basic premise of ethnography, that you are hanging out with the people that you are writing about. You're observing them, but you're also participating in their lives, though this doesn't always happen. We use this term for what anthropologists do, but you're not always like involved so the Julie Livingston article on cancer in Africa, I would say you do see participant observation, because she's actually helping out in the way she can. She's helping explain to some of the cancer patients what cancer is, and she's helping do small chores. She's helping to deliver drugs and this is part of ethnography too. A traditional objective scientific stance would say, oh, you should not get involved. You need to be just observing, hands off. In ethnography, many people feel like there is a moral obligation to get involved, not to unduly interfere, but if Julie Livingston has some skills, or if she's coming from the US and she can bring some cancer drugs in her checked baggage, she will do this. It's considered, you need to be helpful where you can, in the ways that you can. I remember when Biju and I were doing interviews with people who had mental health problems, they asked us for more therapy from us. Because, even though we weren't therapists, and I explained that to them, the psychiatrists had very little time to hear anything from them. But they spoke to us for a long time about their whole story. Sometimes they would be in tears, and they found it therapeutic. The intention was to do interviews, but they also felt like telling their story, having someone spend time listening, and some people wanted to just talk more. And so, we talked more later on, not sort of even less formalized meetings. So that's, also that's an example of being a participant at the same time you're an observer. And then interviews obviously are central to field work, and yeah. Mm-hmm.
That has been a very common experience, especially about 10, 20 years before. That people here, that is my observation, that they didn't take only research interviews as such. They expected treatment following that immediately.
Okay.
Why should we share?
Yeah.
Their idea about research was, it was not only for research. That was one point. And second point was, doctors don't speak so much with them. So they want they get this privileged time.
I see. Yeah.
Which forms a special bond with the researchers, and then they keep on asking them, we want to talk to you more.
Right. No, thank you for adding that. Yeah, it's the same observation from your research too. Okay, great. Well, maybe we can talk in more detail about Julie Livingston and the African oncology ward. Or the oncology ward in Botswana. Yeah.
So, sir, in a position where we take information from our participants, there's always this ethical dilemma that we are not giving them anything in return. So, how did you deal with it in your fieldwork?
I thought about that dilemma. In the end, I felt what we were giving them is an ear, time to tell their story, and the other way, I've given back of over time was by, through money. We can't pay the participants, but I've given donations to this psychosocial rehabilitation center where people with mental illness go because I know where that money's going. I know the director. I know how they use it. So I figure, that doesn't directly help someone in the mental hospital, but it helps the larger issue of healthcare. And so, like when I go back to Trivandrum, I'll go meet the father who runs the center, and I'll give another donation it can just be that too, to also contribute to one of the NGOs or whatever the institutions are that are helping. So I think that to some degree, and we also are using the larger rationale that clinical science uses, which is that the research will somehow help, humanity, but it will not cause any undue harm or burden to the person. But of course, you have to go through IRB, approval to make sure that, that this is the issue. I really believe that most of the time when we do interview, you're working on reproductive issues, is that right? I forget.
That is not my core area, but that is one aspect of migration.
Oh, it was the migrant workers, yeah. I think, your research and getting issues out there in the public awareness, which is just one small piece of many other other scholars, hopefully helps the situation of migrants. I mean, we have to tell ourselves those things. I mean, we can never know for sure what we're doing if it's helpful, but that may, that's a rationale. That's why we do this work.
So, sir, I was interviewing one participant, and it was through snowball sampling. I had met one person, and then she called the other person to their house, and then when I was interviewing her, she did not let me speak anything. She had already assumed that I am someone from the government who is just here for a survey, and then she lashed out, and she cornered me so much she didn't even let me talk. She was like, you guys come here and you just take information, and then you don't do anything about it, and then this has happened in all our red lights. And then after she was like, I don't know, after she said all those things for like half an hour, she was just talking, and then she asked me that, okay, so you are also like every other person who comes here for our interviews. You didn't tell anything about yourself, you just took information from me.
Yeah.
So then I told her that I am not some government agent, I am a student who is trying to understand. And then she calmed down, she was like, okay, I thought you were from government.
Okay.
You were some kind of survey who like people, most politicians come there to understand the situations and then make false promises, just telling me all those things. So that incident, I felt very cornered as a researcher because I was not, another thing that happened was when I went to a village for interviewing people, women used to come where I was interviewing women, and they were like, come to our house, and then I asked one participant, what is happening? So she told me that they think that you are here from the government who has come here to give some welfare schemes. So that's why they're calling it.
I see. Okay.
So I think most of the times participants do expect something in return, which causes a dilemma in the researcher as well, because I was not able, because anyways it was my final study, so I was not because I had not discussed anything of this sort that I would have to give something in return. Okay,
no, that's a good example for us to learn from. Yeah, I mean, it's probably best to be upfront about who you are, before they decide who you are. Also, I mean, sometimes it depends on the IRB. Sometimes we're allowed to pay participants, but the money should be enough to be, significant, but not so much as to be, to change the whole because the money can undermine the truth. If it's a lot of money, they'll just be, well, the belief is it will not be it won't be of informed consent. It will be for the money. Is one idea that's out there, and. Anyway, let's move on to cancer. So let's talk about Julie Livingston's Improvising Medicine, an African oncology ward in an emerging cancer epidemic. So let's have that up here. Okay, why isn't it? So I'm interested in hearing, actually, Tej, did you have a reaction to this since you work at a cancer center? I'm curious to see if you...
So, I have to read it again, but what I've gathered is, like, it starts off with comparing between, is there any difference between a New York cancer patient
Yeah.
in a hospital versus a cancer patient of an African origin in a relatively remote place like Botswana.
Yeah.
Where they have their own cultural, social, technical, medical issues, which are quite different. And so they compare in a sense. Going through this, it appears that it's more or less in a sense similar that first there is denial of illness. Here they have the cultural part of it. And like saying that if one has AIDS, why will have another illness? They can only have one illness.
Right.
And the other is they are doing witchcraft by giving this treatment, white medicine, chemotherapy, like witchcraft, and they use a term for that, poison or something, without mentioning it.
Right.
And they also say things like linear accelerators, which are used for radiotherapy,
Yeah.
are turning into incinerators for these patients. So where the patient is burned off, where radiation is given. So the way they're making sense of each of these commonly understood chemotherapy, radiotherapy, and surgery were very culturally discussed and described.
Right. Okay.
And that even the surgery part, one would expect probably that someone from New York would find this figure meant more. But here they were refusing some kinds of treatments that would disfigure or in some way make them less a person. So they were those common fears also.
Okay, yeah, so...
And the other was, even in India, waiting times.
Waiting
time, increased waiting
Oh,
time.
yes.
And not talking enough. That some people said that cancer has not been adequately enacted and fully sealed.
Okay.
So probably those are common even in India also, where no one gets enough time to talk to the patient or both ways.
Okay. But, yes.
Sir, one thing that I found interesting is that earlier you mentioned about how, I think it is a good intersection of how critical medical anthropology and cultural anthropology intersect.
Okay, yeah.
Because it shows how cancer becomes socially and institutionally embedded. At the same time, it also kind of demonstrates how the health inequities place at a local level. And adding on to one point that he said, I think it also shows how nurses and doctors are also kind of burdened with an emotional strain to look after the overarching, like there are a lot of patients, right? So
Yeah.
that part as well.
Right. Okay, great. Yeah, no, I think it does, a good observation about marrying the cultural with the critical medical anthropology, which I think has sort of become the standard. Now you kind of have to be aware of both to a great degree. Can we elaborate more clearly what are some of the big differences between cancer in Botswana? I mean, her comparison is cancer in the US. How are they experienced differently? I mean, she really says that they're like different things in those different countries. And maybe afterwards it'd be interesting to talk more about cancer in India and what exactly that looks like in relationship.
The stage of diagnosis in Botswana is very late.
Yeah.
Whereas in New York, it's picked up by screening.
Right.
And then in Botswana, the conversation is in a different way. Whereas in New York, you are given a lot of information. Maybe there are patient support groups. And whereas in Botswana, they may already be having HIV and some other, maybe hypertension. Article mentions my hypertension, my HIV, and now on top of that, I have cancer. So, how that diagnosis is introduced is different in Botswana, and what cure or other effect of treatment means is very different.
Yeah.
Here and in Botswana, for the provider it's different, for the patient it is different, because there is this phenomenological experience of pain, suffering, because it's a late stage.
Right.
So then for them, what improvement means is different from what it means for the provider.
Exactly. Yeah, and the metrics for measuring outcomes, are problematic because there's international standards of 5-year survival rates, which might not be applicable to the situation in Botswana, where the issue is, is their life more humane in some way? But yeah, I mean, you're mentioning the most basic thing, right, which is, later stage encounter with the medical system in Botswana. People are, going in, only when they have like a large growth. They're suffering terribly. It may even smell terrible. I mean, I think most people in the US don't know cancer has a smell because you never experience it that way. I mean, what I came away with the first time I read this was that in the US, cancer is very invisible. Okay, it's, somebody has a cancer patient, you don't know that they are. It's because it's been detected by some scan or some technology. And in Botswana, because they have a big growth on their neck, or a massive breast cyst that's, causing terrible pain. So you have this, cancer is this very visible thing. It's experienced very differently, by both. And yeah, the idea, the knowledge about cancer among the patients. You grow up in the US knowing what cancer is, and you are inculcated with fear, that motivates you to do screenings to make sure that it's caught at the earliest stages and preventable. So in Botswana, you don't know what it is necessarily until you are lucky enough to be, referred to one of few places that can do anything about cancer, like this hospital. And as Livingston explains, many people never get there. They never get the right referral. They go to local clinics that don't know how to diagnose cancer, but some people eventually do and end up there. How is cancer in India? I mean, is it similar? I did once meet a PhD student at JNU who was working on cancer in India. I remember his discussion made it sound like it's kind of like Botswana and kind of like the US. That there are cases where people only get diagnosed at an advanced state where it's a visible, horrible thing you can see, disrupting the family life. I mean, my sense was that was among the poor, people with less access to services. I'm imagining the Indian middle class experience is going to be like the New York experience that she compares, where there are regular screenings and cancer is not visible. It's something you just know is there through indirect technological intervention. Is that correct? Or how would you say cancer looks and is experienced in India compared to?
I feel there are lots of correlations between Botswana and Africa and in India also.
Yeah.
And as Livingston mentioned in her article, most of these cases are in the late stages identified. Like continuously in the news article, we are also reading this. There is initiatives to create awareness about it, but still it's not common among these people to go in for mammograms and all. It's not common.
Okay.
Still, we need lots of awareness programs, something like that. However, government taking some initiative for giving free vaccination for cervical cancer and all. Now it's in process.
Okay.
But still, I could feel this cultural embodiments with going and approaching that still persist in the society, which need to go long way.
Okay, okay, so some similarities to Botswana, okay.
I think it's a mix of both Botswana
Yeah.
and New York. It depends on the class where
Yeah,
the person hails
right,
from.
okay. Yeah, so middle class Indians, will they go for, like, will women go for breast cancer screenings? Will men go for prostate screenings?
Upper middle class, I would say.
So upper middle class, I see, okay. I know, because,
HPV vaccines that she was talking about has become a common thing nowadays, and not many women from the lower strata would know that.
yeah, okay, yeah, they may not know that, right, or be able to get in for screening easily, yeah.
I listed in the article, there doesn't seem to be too much stigma related to cancer in Botswana. Whereas in India, there's a huge amount of cancer. You call somebody and say, I'm here to see if you have, to check
Yeah.
if you have cancer, they run away.
That's an interesting point. I think you're right. I think, and actually, since I've read the whole book, I can tell you in other places too, that she has a chapter on laughter, on how people laugh. You know, of course, it's dark humor, you know, around cancer. It's one of their ways of coping with it. But you see a little bit of that even in this chapter, that they're not, yeah, so it does seem, at least in the hospital, less stigmatized. That's a good point. Remember there was that one patient who says, like, you know, even though the lion may be coming, I'm ready, you know, explaining his readiness to confront the cancer. Yeah, I think that's probably the case in the families. But you know, we only really have this slice of view from the world of the hospital, where these people are you know, the staff themselves are very compassionate and devoted to helping their patients.
Can I just add one?
Yeah.
I really enjoyed reading this article, is that the author kind of gives equal importance to how cancer is created in New York, to how cancer as a category is created in Botswana, without kind of saying that this is state of the art or very good and this is. So that value which the ethnographer was bringing to the knowledge category, in US or Botswana, the same. For me, I think that
Okay.
is very.
Okay, yeah, a good point. I mean, in fact, she's perhaps somewhat critical of the standard of care idea, you know, and she shows how it's really, you know, the cancer research is operating in a different world from what we see in Botswana. Yeah, okay, no, but that's ideally what the ethnographer should do, be able to depict it that way. And you're saying, you know, a cancer is created in a different way. Yeah, that's her own terms. It's like not, you know, of course the biological process of cell growth is there, but how it appears, I mean, it's physically different, you know, in the two places. It is, and how people know it, it becomes an object. It is sort of a created object. The conditions of sort of lack of oncological care in Botswana have made big tumors. You know, there's this actual social condition results in a physical, yeah.
I have one question.
Mm-hmm.
Like in North India,
Yeah.
even lower middle class and middle class people, any pain or something, they go to a private clinic, and usually an MRI or PET CT or those kind of expensive investigations are advised.
Right.
They go to a private practitioner, they shell out money, get the report, and then they go back to the private practitioner who tells them that this is cancer, you have to go to a government hospital. They go to a government hospital and they are in a waiting line. And the doctor says that you are in waiting line, your treatment may start after 4 months or 5 months. And if you don't take treatment early, it will progress and it will become, and you will get to an advanced stage of cancer.
Okay.
So, like, I don't know how it is in Kerala here, but everyone knows at an early point that they have cancer, but they're running around getting access to these higher forms of treatment.
Right. Okay.
And what I want to understand is, even if it's New York City, how is it possible that everyone has timely access to care?
Well, not everybody does. No. Yeah. So the U.S. has complicated problems with healthcare access, mostly because it's a system based on private insurance. But if you're old, you get Medicare, which pays for all of your healthcare needs. And if you're poor, you get something called Medicaid that also pays for healthcare, but fewer doctors take Medicaid. Fewer doctors participate in that access for the poor. The idea was that, so if you're old, you have government coverage. If you're poor, you have government coverage. And if you're working, your employer will provide health insurance for you. The truth is millions of people fall between those cracks. And that's, so and there's many complications, though even there are, and New York actually is not a good example for her article, because New York has these top cancer institutes that you don't find, in every US city. She might have taken a more average, smaller city as an example. But I think but basic screenings, are pretty much universally available. If you have Medicaid, or Medicare, or if you're uninsured, there was something that was called Obamacare, created by President Obama, that was supposed to plug the gaps of the uninsured, but the gaps are still there. But in all of these scenarios, you're able to get screening. The screening is usually easy to get covered. If you have Medicaid, because you're poor, you might have to do a little more work finding a doctor who accepts Medicaid to do the screenings, but they are there. So that's an issue in terms of who gets access to elite care. To some degree, there's a system of triage, where, there are people who have, little money, who are on Medicaid, who do get treated at some of these top hospitals, if their case is very distinctive. If their particular cancer is unusual. Usually if you are able to make a claim that your cancer is not treated by some normal thing, you need to go to a specialist, you may be able to. But the insurance company sometimes will work hard to not approve that referral. So there's a complicated bureaucratic economic system behind this. So, but the basic screening level, I think it's pretty good. But medical bankruptcies, personal bankruptcies due to excess medical debt can happen. You can get cancer and you can be cured, but then you can be in debt to $200,000, and then you might be able to negotiate with the hospital, but it's not a good system. Some things are good. Medicare for seniors works very well. Everyone is happy with that. But the U.S. is unusual for like a high-income country. In all of Western Europe, everybody has free government-supported healthcare, at all levels, which they pay for through higher taxes, which I think is fine. Anyway, one other thing. Let me just look at my notes. What did I write down about Livingston? Yeah, let me just give a couple quotes from her work that I thought are poignant. And to some degree, this overlaps with some of the points some of you have made. Page, where are we? 66. So this paragraph that's highlighted there at the top, cancer in Botswana differs. Zoom in a bit. Cancer in Botswana differs from cancer in the global north, where it lies at the heart of cutting-edge, highly capitalized biotechnical research and of public narratives about loss, heroism, and hope. Botswana is so far in the periphery of the oncological imagination that its biological, epidemiological, sociocultural, and technical context is beyond the conception, much less the concern or evidentiary basis of most oncological research, with its emphasis on new drugs, expensive screening technologies, molecular and genetic knowledge, and interventions and costly procedures such as bone marrow transplantations. Okay, so there is cancer research is like what you just heard there. It's all about new drugs, looking at the genomic level, the molecular level. is irrelevant to Botswana. And in another chapter, she explains the drugs they have there are generally like what you used 30 years ago, they have many old medical journals also, like from 30 years ago. But then she points out that actually it's appropriate because those journals talk about the reality that they work in. They're about the drugs that they actually have in stock. And this kind of this lower quote elaborates on the same point. Evidence-based oncology protocols published in the leading medical journals do not address what to do when etoposide, 5-FU, or cisplatin, all core chemotherapy drugs, suddenly go out of stock, as each did for some time in 2007. Thus, in order to envision the possible futures of Botswana's cancer patients, their oncologists must borrow, adjust, and even deny, but never simply import metropolitan knowledge. I think that last line is really good. So metropolitan knowledge is the cutting edge cancer research, the stuff that gets all of the focus in the scientific journals, and that knowledge is something that the oncologist in Botswana must borrow, adjust, or sometimes deny, but they can never simply import it or adopt it. They have to be and the book is called Improvising Medicine, okay? They have to be improvisational about the standards of care, working with, at one point in this article, she calls Dr. P, what did she call him, an artist, I think it was the word. That his work is artisanal and empirical. That he's kind of, uses empirical knowledge and like the artisan is sort of crafting individual treatments. We're told that, the histological exams may take too long to come through, and so he uses more indirect methods of diagnosis because he will need to start treatment sooner. These tools that have standardized, regularized ways of using them and standardized forms of diagnosis, he can't really engage with because it may take too long to get the lab results back, before they're able to know. So it's improvisational, and it's artisanal, but it's also empirical. Let me also show you something that you may have noticed in the article, something that she does that anthropologists often do. So here on page 67, and there's examples all over throughout the rest of this article. She says, here are a few moments from my field notes on an unremarkable June day in 2008, which underscores the necessarily empirical nature of Dr. P's work. And then she's actually quoting her own field notes here. That's why you have it indented with italics. And then she continues for quite a while doing that. And it's useful. She kind of is showing you how she depicted things that are happening at the hospital. And then she returns to the discussion here. And then she does that a few times later. That's also part of ethnography. Many anthropologists do this. But I don't like it. I think it's like, don't do this. It's my view. I mean, to me, the reason, so what other people do, the reason you have field notes is they're notes. They're used to depict the ethnographic situation, but you take those notes and you write a narrative out of them. You don't quote them in their original form. You make it into more, just take your time to be a better storyteller, not quoting the original thing. And I've done that in my own work. I found some of the best ethnographers, they're telling the story. I was walking along the road, I encountered this person, we had a conversation about this. If you quote your notes about that, it's not as interesting unless you just take some time to reconstruct that. To write ethnography, you need to develop some of the writerly capacities of a novelist or somebody who does like narrative nonfiction. And I remember in my second book, India and the Patent Wars, I was working with an editor at Cornell University Press who herself is an author of many books. And she was a professor in nursing, but she was also a journalist. I think actually journalism was her main designation. And she didn't like my academic style of writing, which is of course the style that she deals with all the time. She wanted me to write differently, and I struggled to do that. But I ended up, I think, writing better because of her pushing me. There was some time when I discussed interviewing pharmaceutical representatives in Hyderabad. I interviewed pharmaceutical representatives in New York and California and in Hyderabad, and I forget how the work was originally, but she wanted me to kind of depict Hyderabad as a place more. To me, it just was a place where the pharmaceutical companies are. And I went and interviewed them, and I have some discussion of who they are and how difficult it was to get those interviews as well, and where I spoke to them. But she got me to elaborate more, and so I came up with a way of saying, what is Hyderabad? Okay, I mentioned the pharmaceutical companies are in these new parts of the city, Gachibowli, I forget the names of the other neighborhoods, high-tech city. and I said that this is just the latest expansion of Hyderabad. Hyderabad goes back to originally Golconda Fort, and I give the years of that. It's a fort you can still see as a tourist, I say. And it was like the city. But then the first expansion of Hyderabad was to what is today called the Old Town, around the Charminar Monument. And then, I describe, later expansions and these all happened with different kind of regimes of power and money, the medieval regime and the Golconda Fort, the regime of capitalism building Gachibowli and high-tech city. And in more detail too, like I said, you arrive at the airport in Hyderabad, you get on the highway in a taxi, you think and you go directly to high-tech city, you think you're in Los Angeles. You don't, the physical look and the infrastructure are very much like a Western city, and so on and so on. I had to elaborate on Hyderabad as a place, and also speaking to pharmaceutical company representatives in these, like this kind of room, fluorescent lit offices, is something that we just take as normal, but it bears description. I explained that I met them in the same kind of office, the office space, the similarity of office space and some points of difference in what the cafeteria was like in the pharmaceutical companies, et cetera. I mean, I did I think a better job of writing it up than I'm explaining here off the top of my head. But the storytelling is something we have to learn to get out in our writing. Some do it better than others, and then you can also use that ability when you discuss the literature review as well. She wanted me to be less jargony. Like, what if you try to explain the social theory to an educated person who hasn't actually done a PhD in social science? Like, oh, it's more challenging. So anyway, so this I think this isn't the ideal way to do it. I think she could have just told us a story. I mean, a true story. It just starts as we search for blast in a bone marrow slide. So you can actually introduce that scene. Where are you? You end up helping Dr. P with something. And does he pause? Does he step back for a minute and say that? I mean, she'll in the rest of the article, when she's not quoting herself, she does do that. She'll talk about Dr. P getting angry, his mood, the improvisational things that he does. Yeah. Mm-hmm.
Like you were showing Paul Thomas 2 days back.
Yeah.
And today Dr. P.
Yeah.
So practically when we work in a health system, it's a health system where a lot of actors network and work together.
Yeah.
And it appears almost when they read these pieces, there is one hero figure who's trying to correct the system and facing all the obstacles.
Right.
Whereas the nurse within or his deficiencies or limitations,
Uh.
he's only able to go this far.
Yeah.
Similarly, the other staff,
Hmm.
the non-doctors, who's about. So it seems like a film where, but is it for the sake of putting it on piece to put everything in one person, that he's the pro and he's the positive and he's fighting the entire system? Is it artificial or is it?
It's, I think both. In one of the earlier chapters, she talks about Dr. Paul and how she represents him and who all the staff are. You know, he gets a lot of attention because he's the only oncologist. I mean, she also mentions that for a while there was an oncologist from Cuba there as well. And I mean, in a way, she says this is problematic. You know, you have this space where you have a German doctor working here, but you know, she wasn't going to go searching for a hospital with only African staff to somehow find a more authentic oncology. Besides, she wasn't finding that. You know, there is kind of a slightly international staff, but she spent a lot of time in the chapter focusing on how the nurses, who are all from Botswana, and you know, and the histologists, pathologists, other doctors are all Botswanan, and they're all central to the whole making things work. In fact, the nurses probably do some of the most important work. I mean, Dr. P does some important decision making because he's trying to diagnose and figure out what treatments to use with the limited tools, but the people who actually have to administer, you know, the chemotherapy, I mean, it's sometimes him, sometimes he does a little of everything, because I don't know what motivates him. Some people are motivated like this. But it's not all him, no, not at all. And, you know, you know, some of the other people have the most, you know, jobs that are just as difficult, you know, cleaning up the vomit, you know, for example, you know, and helping people to throw up, you know, as the nurses have to do. You know, something I also learned from that same editor that helped me revise my book, she's actually written several books about nurses, kind of like not, you know, journalistic, compelling, exciting stories about nurses. And what I've learned from her is the nurses are the main people in the healthcare system. They're the ones who do the care, especially like in an oncology clinic. You know, sometimes the patient will see the doctor, you know, twice a year, but they'll see the nurses over and over and over again. The nurses are actually administering the treatment, dealing with the side effect, making all kinds of decisions on an everyday basis. That's in a way, the real center of the medical system in one way, if you look at the most crucial labor that's involved. I think this book is also useful. I guess we should be taking our break soon, just because it is about cancer. That's one of the reasons several years ago I chose I taught the whole book in a class. Because as several critics have pointed out, when people are looking at Africa, sometimes they're looking at traditional healing, like we read an excerpt from Stacey Langwick's book. But they're often looking at HIV/AIDS. That became like the thing that everybody, and you might notice how in her description of cancer versus AIDS, that there seemed to be a lot more awareness of AIDS and preparedness for AIDS. And remember the cancer, some patients even said, I would just wish I had AIDS, not cancer. So there has been a lot of money put into HIV/AIDS in Africa. And I mean, it's still, you know, many people die and never get diagnosed, but many get diagnosed, get on the antiretroviral drugs and live full lives for a variety of reasons, including India pharma companies and UN and other NGOs. So critics have said, you know, there's too much interest in AIDS. Not that AIDS has been solved, of course, you can never say too much, but relative to other problems in Africa, you know, people think of Africa as a place of AIDS. They don't think of Africa as a place of cancer. You know, every place has cancer, but we tend not to. So she's looking at this, you know, lurking problem that's just right, you know, that's just right there that everyone has overlooked. I guess in a way, you know, cancer was not a sexy topic. You know, AIDS was.
So why is that?
Why is it good? I don't know. I think the awareness about AIDS spread really well. I mean, you saw some of in that film, right? Some of the people, like the demonstrators at the international AIDS conferences, which got a lot of press, a lot of media press. They had die-ins. I think that among people who would be donors, there was more awareness of AIDS. And I think that people tend to associate, you know, exotic diseases. Well, AIDS is not exotic, it's everywhere. I'm not, you know, I think, who knows? It could just be that there's more media awareness because of activism about AIDS. And I considered working on AIDS in Africa too, I mean, in India too. I ended up working on the patent struggles, but it related to AIDS because it was about the AIDS drugs. And I do remember meeting one C.R. Soman, who was a professor of public health in Kerala, who had an NGO called Health Action by People. And I was kind of poking around the AIDS topics, and he says, there's too much on AIDS, you know, too much research being doing on it. People need to figure out the problems of obesity, you know, and high blood pressure and things like that, you know, in Kerala and South India. And I thought, good to hear somebody with a more expansive perspective on it. You know, AIDS just lit up everyone's sensibilities, and probably because it was dramatic. You know, it was a death sentence. You know, no one survived AIDS unless they had these medications. Anyway, let's take our break. You know, we're well past 11. Oh, what's that? Oh, is yet to arrive. Okay. We'll keep going for the sake of the tea. Okay, so let's move on to the next reading. Oh, Cecilia Van Hollen. So Cecilia Van Hollen, Invoking Nwali, Painful Technologies of Modern Birth in South India. She's dealing with this intrigue, this puzzle to her, of the fact that Tamil women demand Pitocin, oxytocin-inducing drugs that make the labor process more painful, but do not demand the anesthetics that normally go with it in some other place. You know, the comparison is to the U.S. or to northern countries where it's just automatically assumed you'll get the pain. I know some of you are working on reproductive issues. Is that right? You had some interest, and did you too? Yeah. Did any of you have any thoughts about invoking Nwali and what you got out of it?
Actually, this is a very interesting article.
Okay.
I never had this insight that people would associate the pain with so many things. That is, like to get a healthy baby, the mother has to go endure so much of pain.
Right. Mm-hmm.
That is, it's a part and parcel of being a woman or to gain Shakti.
Right.
So that is totally way off from the medical concept. So we think of getting a healthy mother and a child. The pain is not an element to try to eliminate it.
Right.
Whereas in this, it is like culture, society, political, everything is involved in the birth and how the procedure of birth is, rather than what is the ultimate output. That is a mother and a child. The mother need not die because of giving a child birth. It should be a happy moment. Whereas it is like amplifying a woman's pain, and that is, it feels more painful actually reading that.
Yeah.
Being a woman and
Oh, yeah.
in India, that is one thing which makes a lot of change in the life of a woman, but it is not so much of meaning from society. But one thing good is, I didn't know that when it is a home delivery, now in Kerala we have more of home deliveries.
Wait, I'm sorry.
In Kerala, whereas it is not coming to the level, right? But it is, there are home deliveries taking place.
Right.
So,
Yes, home deliveries are increasing.
yeah,
Last year,
by
especially.
home delivery, do you mean like natural birth movement?
No, like
Deliveries at home.
home delivery. Like last year,
Okay.
This,
Especially the unwed mothers.
not unwed, this.
So recently many cases came.
And so many things have, I didn't know how to go through this article. This small topic can be such a, it will be at the junction of all the social, political, religious, medical, non-medical, so many gender, and the husband should not come in, why should not the husband come in? So those are all perspectives which has been very, it's very good article. I thought
Okay.
that tell me students, so much you can learn from just one article.
Yeah.
What are the social implications of how a lady takes on the view of how she becomes a mother? So many things. I think it was very good article.
Okay. Oh, good. I'm glad you like it. I like it too very very much. I think it does. It comes at it from so many different angles at the same time. Other thoughts about?
Yeah, like in this article there was like there was like both opposites, like the biomedical side of it as well as the cultural side of how pregnancy was viewed,
Okay.
as well as the word Bali itself means like pain and strength.
Yeah.
So it's like very opposites, and there were women who, I think she asked the question, like, what do you take to reduce pain?
Right.
They couldn't understand the concept
Yeah.
that you take drugs to reduce the pain.
Right.
Rather, they wanted drugs to increase the pain because that was where motherhood is. That was where womanhood
Yeah.
is. So that is like suffering equals womanhood, or suffering equals the whole identity of them being a woman. And also there was mentioned that being a mother of a son was also important. It shouldn't be just being a mother, it should be mother of a son. And also, like in my pilot, like here, like they said, like they didn't know like they couldn't understand or grasp the concept of having an what do you call it, epidural.
Oh.
So in my research, like not exactly that, but it's like when they had pregnancy loss, they didn't have much time to take any decision or to process the loss that they had in pregnancy loss, and they had to quickly go into have a medical intervention to remove the pregnancy or the parts of the conception,
right.
like the remnants of the conception. But they thought that they would just go into the surgical room and like would be put to sleep, and when they wake up, they're like, okay, the surgery is done,
Right.
like the remnants or the fetus is removed, and that's it. But like all of the women, they didn't know that they have to go inside. They would have to be like induced labor. They have to give birth to the fetus. Like it was like for them, it was very traumatizing the act of giving birth, because they have never, they never knew that they have to actually give birth to a child they would never bring home.
Yeah.
So that was traumatizing for them.
Yeah.
And also here she said that in an urban hospital she actually observed the women birthing. So that was very interesting, because like how did she do that? Like how did she get access to actually go inside and actually view how the whole birthing process was going on in India, like in the urban hospital. Also, like she said, like husbands were not allowed to be, like they were not informed at all, like the women were going into labor. Rather, they would be just told like, okay, this is the baby.
Yeah. Right. Yeah. Yeah. Here's the baby.
So that is very baffling, and there must be women, like despite being told that this is how women give birth there, they might be feeling that lack of support from their partner, the women. Also, I wonder how the husbands felt when they were not informed at all about their wife going into labor, or that just giving the newborn baby to them. Also here, like somewhere it is mentioned that infertility was very much like stigmatized. So
Yes.
I wonder, like in her research, she didn't touch the topic of pregnancy loss and fertility. But I wonder how during that time in that community, how was that viewed? Because if they were undergoing like multiple pregnancy losses or they were having infertility. Again, during that time, like even still now, like women would be the one who would be like stigmatized or pointed finger at that this is because of you. Or
Okay.
this is, you are the reason that both the couples don't have a child
Yeah.
or something. And I wonder how were they stigmatized or like were they like just pitied or maybe how did they feel or how were they represented or viewed by that society?
Okay. Yeah, those are great. Thank you for your observations and questions. I mean, I wonder. Yeah, I mean, obviously she doesn't talk about some of those things in there, but you might want to look at her book. You know, so after this article, she published a book which I haven't read. I only know this article. Okay, so I'll just show you this reference, and then we'll have tea.
I think it's Cancer and the Kali Yuga.
That's another. Actually, that's on my to-read list. It's very intriguing. Cancer in India is one of her newest books. But then she did, I think it's called Birth on the Threshold. So yeah, she eventually, you know, and by the way, this is what happens in academic publishing. You publish an article or two or three, and they end up being revised into chapters in your book. So this is like you know, she will have made the same discussion along with a lot of other observations in this book.